Strategic Clinical Lead Commissioner for mental health in that area. And currently I work with London Ambulance Service, particularly in their 111 service, as their clinical lead in South East London. And one of the things that I do in there is to make sure that there's representation, and the system that we deliver tries to meet the needs of our population as much as possible. Obviously, there's still a long way to go, but we are working actively in that area. The other role I have is the clinical lead for Healthy London Partnership, which is in collaboration with NHS England, where we are currently working on community services for eating disorder. Eating disorders includes anorexia, bulimia, and binge eating disorder, as well as a myriad of other eating disorder conditions. And one of the key areas we are looking at in that work is to increase awareness in the Black community and to increase referrals into the service. So I'll just move to the next slide. And my other role is I'm the founder of Black Mental Wellness UK, which is a community service which aims to improve mental health literacy and awareness in the Black community, which is why I agreed to do this presentation, and also to support like-minded organizations like myself through networking. We share resources and try and inspire hope through amazing stories, journeys, works being done across the country, and also to try and work at increasing the provision of services for the Black community. So I'll jump into the presentation. So depression generally can be defined as a symptom of feeling of persistent sadness that you feel. To diagnose it, if you went to a GP, or actually I think you can diagnose it yourself, the symptoms that one recognizes when you have depression can be divided into two categories: core symptoms and other symptoms. The core symptoms include things like low mood. So you may have a feeling of persistent sadness, low mood. Some people may feel tearful, some may not. Another core symptom is the loss of pleasure or joy in the things that you usually enjoy doing or activities that you usually do. The other symptoms on the right-hand side I've listed include sleeping, so disturbance in your sleep. So you may notice that you're sleeping either too much or sleeping too little, or you have broken sleep. Some people also may find that their appetites change. So you may actually overeat and put on weight while you're feeling depressed, or you may undereat. So you may lose weight when you're feeling depressed. Some people may also find changes in their energy level. So some people may slow right down and have no motivation to move or do anything. And some people often say, I struggle to get out of bed. I don't feel like getting out of bed. Or some people, it's the opposite, where you feel agitated and you can't sit still. Sorry, that's the next bit. So movement. So you may feel agitated or you can't sit still. With energy, your energy tends to be low, and you don't have the drive to do the things you usually do. Some people may feel that may notice that they have a loss of concentration. So by loss of concentration, you may not be able to concentrate at work, concentrate with family members or anything, even watching the TV. You watch a whole program, but you realize you didn't quite remember what happened through the whole show or program that you've just watched. Some people have a feeling of loss of self-worth, low self-esteem, feeling like everything you do is a failure. And also some people can feel suicidal, like people may describe, I don't feel like being here anymore, or sometimes I go to bed and I wish I never wake up again. So those are some of the symptoms people can present with, but actually there's a caveat. Some people present with physical symptoms. So although it's a psychological issue that's going on, people may present with physical symptoms, which may include headaches, persistent headaches. Some people may have abdominal pain, dizziness, pins and needles. So there could be a whole range of physical symptoms. And what I tend to say to people is, whatever your symptoms are, seek help from a health professional, because they first need to exclude underlying causes for those physical symptoms before you can make a diagnosis of depression. And so moving on from once you've been diagnosed, once you've recognized that you've got those symptoms of depression, the next stage is a diagnosis. So to diagnose, you need 5 of the 9 symptoms I've described above. So those 5 symptoms could be any of the 5 symptoms on the right or on the left, so the core symptoms or the other symptoms. And it must include one of the core symptoms, so either your mood's been affected or your enjoyment and things been affected. And the other thing is it affects your function, so the things you do day in, day out, and it occurs most days of your week. So you feel that way most days of the week, most parts of your day, and as being persistent for at least 2 weeks. The other thing we must pay attention to is you have to make sure there's no other secondary causes of your symptoms. So by secondary causes, we mean things like medication, side effects of medication that may make you feel depressed. Drinking too much alcohol. I know a lot of people drink alcohol because they can't sleep, but then what then happens is the converse, which is that your sleep then becomes affected after you've persistently drank alcohol excessively for a long time, and it can then affect your mood. Other things could be taken. Recreational drugs can also affect your mood, including cannabis, cocaine, any sort of recreational drugs. And other secondary causes are things like problems with your thyroid, your pituitary gland. Those can also present with symptoms of depression. We then classify depression in terms of mild, moderate, and severe. To be in the mild spectrum, we say you have 5 of the 9 symptoms, and your daily function, the way it impacts on your daily activity, is mild. For moderate, it's usually 5 of the 9 symptoms and 2 of the core symptoms. So your mood's been affected and your enjoyment in things is being affected. So lack of enjoyment, we call it anhedonia. And then also mild to moderate impairment of your daily activity. And then severe end of the spectrum is most things. You have most of those symptoms and it markedly affects your function, that you usually need support from other people to get the things that you need to get done. There's some diagnostic tools that we use in a clinical setting to diagnose people with depression. So there's a patient health questionnaire, PHQ-9, which you can actually get online, and you can do that on yourself. And also I have it on my Instagram page if you wanted to go on there and take a test. And also GAD7. Sometimes depression can occur with other symptoms. So you can have anxiety with depression. So we'll do a GAD7 on you, so general anxiety disorder diagnostic tool that we use. Other types of depression that's related to depression is bipolar. So with bipolar, you have the person has symptoms of being very high, so the manic state, and then the low state, which is the depressive part of bipolar. And then there's a group of people that have what we call SAD, so seasonal affective disorder, which is where in the winter months, from about September, when we start losing sunshine, some people can get symptoms of depression and do get diagnosed with depression, and they would usually have the same symptoms I described above with general depression, so the mood, the core symptoms, and the other 7 associated symptoms. So the statistics in the Black community, which is why we're here, and I'm doing this talk specifically for our community. So we know that generally, and in the Black community, depression affects 25% of the population in their lifetime. So 1 in 4, if you line 4 people up, 1 out of them would have experienced depression at one point in their lives. However, the picture institutionalized when we have mental health symptoms, and also we're less likely to receive care in a timely manner. And I think that actually is part of the reason why we're more likely to be sectioned under Mental Health Act. I think because we don't have access to treatment early enough, what can sometimes happen is your condition deteriorates by the time you get the help you need. And also, there are other factors that make us more likely to be sectioned. And I think it's because the services we have do not cater for our community and don't know how to manage our community effectively. So we're more likely to be sectioned. And although these statistics are discouraging, I think it gives us a tangible target that we can work on as a community to make sure that the access to service changes and the narrative changes for our community. And so the cause of depression, some people, there's no known cause. You just feel low, you don't know why. You can't put your finger in it. Some people are just more prone to it, and we don't know why that is. There are some people that it's genetic. So you may find that there's people in your family that suffer from mental health issues, and you're more prone to it because of the genetic factors. It's a heterogenic picture with the genetic basis of that presentation. Other causes could be your environment, and by environment I mean it could be a traumatic thing that's happened in your life that's triggered that depression. It could be something in your childhood. It could be caring for someone who has mental health issue, could be the trigger for that depression. Other causes in the environment could also be work stresses. So problems with workload or not being happy in your work environment. Other things could be your house. If you have poor housing, we know that can also affect your mental health. And environment also could be the people you have around you. If you have negative people around you, that can also trigger depression. With women in particular, we know that when women go through menopause, it can affect your mental health. So women go through menopause about the age of 49, late 40s to early 50s, and we diagnose it as menopause if you haven't had a period for more than 6 months. And in that group, what happens is the change in your hormonal balance affects your mood, and you find that you're more irritable, agitated, and sad and tearful. So we find in that phase of life, you can be more depressed. And what we tend to say in that phase of life is to increase awareness. So particularly when you're heading towards the late 40s, or you can have early menopause. So when people have menopause at a very young age, when you think you should be fertile. So I tend to tell people, have a plan. So a plan, read up on the condition, on menopause, read up on things that can help you and seek help early. So try and identify where you can get help before you reach that stage. Another thing that affects women, particularly Black women, is postnatal depression. So that's being diagnosed with depression. In the medical field, there's debates about when you class it as postnatal depression. Overall, you can say if you feel depressed within the first 12 months of giving birth, we would give a diagnosis of depression, and it's the same as those previous symptoms I discussed. And with postnatal depression, what we tend to find is it could be a new symptom, or it could be an exacerbation of a previous previous depressive episode. The triggers for postnatal depression can vary. It could be a traumatic birth. It could be an unsupportive environment, a strain in your relationship, hormonal changes, or the stresses of having a child and not sleeping. So it could be a myriad of reasons why you may feel depressed, and it's actually quite common. Up to 10%, up to 20% of women can get postnatal depression, and I think it's important for us to normalize that in our community so that people can seek help and talk about their feelings. And what we find with women, the pressure they put on themselves to be good mothers, breastfeeding, making sure your child's in a routine, can actually be a big pressure and affect your mental health. So I think it's important to normalize the fact that there's no perfection in motherhood, and that we're a community that can support our women, and we can signpost them to the right services to get the help they need. So the Black narrative, I called this, is I think the issues with us getting the help we need and us getting it in a timely fashion is important. So I think because of the mistrust we have of the system and the historic things that have happened to us whilst in the system has led to us having a different narrative and not having as being more as supported, and our outcomes aren't as positive as our white counterparts. Mistrust also in our community, because our community generally have been wronged in times past, and I think that affects our trust in the system and seeking help. There are other barriers to seeking help. One could be financial. We do know the Black community tends to be more disadvantaged financially, and that means that we may not have be able to get access to help. And financial barriers could include you can't buy the medication you need to treat to get to get better. It could be that you can't actually get to an appointment because you can't afford the train journey. Financial barrier could also be you can't take time off work because you of that loss of income, or fear of losing your job if you took time off work. The other barriers is lack of understanding. So lack of understanding from the services that we have available, especially if you go to seek help in a service that's not doesn't understand our cultural or beliefs or religious beliefs, that can mean that they don't recognize your symptoms and don't help signpost you to the right place to get help. It could also be understanding in our community. So understanding of the condition. So family members that don't understand depression, and they may use terms that are insensitive and invalidate your feelings. So they may say, oh, get out of bed, you're being lazy, or stop whining. Those sorts of things hinder people from getting necessary help that they need. Also, lack of awareness of the resources that are available in our environment. And those are some of the things I hope I'll be able to touch on. The other thing is the impact of racism on us generally. We know that research has shown that the microaggressions from racism can impact on our mental health and can, I see it as a weight and a hindrance to us getting the help we need. And that racism could be in work environment, home environment, in the community in general. There are also language barriers. So because of English not being your first language, or because you use different terminologies, I think even urban terminologies, lack of understanding of those terminologies can pose a barrier to seeking help. And language barriers in some services. I work in 111, and we recognize that some of the terms we use when we're trying to explore people's symptoms aren't terms that apply to certain communities, and we're actively working to change that. And I think it is much needed work. And the other things are the social and economic inequalities that we see in our society. So we know that we're less likely to do well in school, not through our own fault, not because we're not as intelligent, it's because the services possibly aren't there and the environment's not supported for us to achieve. We're more likely to be in contact with the criminal justice system. And what we find is actually a lot of people that present, sadly, the first time they're presenting to our services is when they're in the system, which is wrong. Also, we're more likely to experience poverty and homelessness, as well as the other things I discussed above. And as I said before, stigma in our community and lack of awareness is also a huge problem. And I think sometimes I can use religious settings, for example. But I think there is a big change within those settings to recognize mental health. But I think before, in the past, people can attach people feeling depressed to they may say, prayed away without other supportive things that could help you deal with the condition, or people having a deemed view of medical services to support you. I believe you can be a religious person, so whether you're Muslim, Christian, and tie that in with medical practices, they can work together harmoniously to help you reach a more positive mental health space. And I think changing that narrative in our community is very important. So why do we need to address it, particularly as Black women? I think because we recognize that mental depression can affect your productivity, productivity in getting the things you want to do. And Black women we hold a crucial role in our society. But I think the fact that we're coined as strong Black women is actually something that deters us from getting the help we need, and actually that then affects the productivity we think we should have. So if there's one thing I wanted us to discuss is the fact that being a strong Black woman and getting help doesn't mean you're no less strong than you were before you got help, and actually being honest with yourself and getting help is a sign of strength. And I think it's something we need to encourage in our community. Also, the impact of depression on our loved ones. We do know that children of parents or children who grow up in environments where children have, where their parents or their carers have mental health issues it can impact on their own mental health and can make them more likely to have mental health issues. And I think making sure you get help in a timely manner with a supportive environment, and actually talking about it openly with your loved ones, means that impact is reduced on our loved ones. And us as a community, I think us starting to change the narrative and talking about depression will help us as a community to grow and also get the help we need, and also achieve the things we want to do in society as a whole through signposting and supporting ourselves. And also creating services for ourselves that we co-produce, co-design, and run ourselves, I think is an important thing. And and which is why I am particularly encouraged by the work CAHN has been doing over the last few years. What needs to change within the system, and as I said, when I was a health commissioner, when I worked as part of my job in London Ambulance Service, as part of my job in Healthy London Partnership, there's now a push to have
Rebecca?
That's the whole myriads of
Hi, Rebecca. Rebecca, it's Ngozi here. We lost you for about a minute. Hello? I'll just try and contact her directly because she probably doesn't know that her camera's frozen. Okay, while we wait for her to come back, I think what we've heard so far is really interesting. I think she's going to log off and then log back on, but I'm just looking at some of the comments here. I agree with so many of them, and I think we'll have an opportunity to put some of these comments to Rebecca when she comes back to us. Women of worth, I like your comment about disliking the terminology strong Black women, because I agree, it doesn't allow for vulnerability, and many of the issues that we see, especially maternity services, many of you will know that as a Black woman, you have a much worse outcome when you go in to have a baby. And I think part of that is that we're viewed to be stronger and perhaps not given the support that we require in terms of pain relief and access to things like that when we're in in that position. You may remember, for those of you who have joined us over the last few months, we had a anaesthetist who came to tell us about pain relief in labour and in pregnancy back in April. That was a really good one to look at for any of you that are out there, so that you understand what to ask for when you are going through labour. But many of these questions, there's some private questions that have come through as well. There's somebody here asking, sharing their experience on how mental health, the diagnosis of mental health has affected them at work. And it's really important that you know what your rights are. I think there's often a stigma, so people don't want to share the diagnosis, but in actual fact, there's some things that you can get that will support you through that. I've had people who've worked with me who have just needed time off for having issues, and that has been really helpful for them, really. The other thing I'd like to say is that during the last few, well, it's now, I keep saying the last few months, but it's a year and a half. We know that the pandemic has had a great impact on people's mental health. I think at the beginning, we saw this as an opportunity. People in lockdown were with their families, many people, but then as it went on, and the impact of, first of all, on our health, for me as a Black doctor working in the health service, one of the things that concerned me right at the beginning of the pandemic is that I saw many doctors who the majority were from a Black or Asian background, who were having really significant consequences of COVID and were dying. So that was a concern to me. And I know that for many Black doctors, many Black women who work in health services, to see the number of people it was affecting in that way, who were from a similar background, had a profound impact on us at the time. We'll just see, I'm sure, Faye, if you can try and contact Rebecca directly, because I think it's gone off now. There is a hand up. Doretta, did you have a comment you'd like to make?
Yes, I did. When we're talking about Black women being strong, I mean, I do agree with that term. I don't like to hear that as well, because we do have emotions. But one of the things that I find is that it's fear of reporting that you're feeling stressed or depressed or full of anxiety, because you're frightened that when it goes onto your records, that you'll get put into this sector, or they'll section you or do something, because they never seem to have time to analyze or discuss it with Black people. I find that straight away they diagnose you, they give you this, and then next thing you know, they section you if you come out in an outburst, and it's quite frightening. So that a lot of women are fearful of that. And when it comes to postnatal depression and prenatal depression, you're frightened of saying that because you don't want to lose your children. Because I know many Black women who have lost their children through postnatal depression, and a few friends of mine as well. And I was quite blessed that my parents were strong to keep me together when I went through postnatal depression. And it's not a nice thing. It really isn't a nice thing, and it's quite hard to deal with. I can't speak with it now because it's quite emotional. But if I was to ever talk to you about what it felt like and what you went through and how you were, it's not a good place to be in. And to think that if you would have gone to the doctors and thinking that you could trust them, that they would have done something completely different that didn't need, if they would have done what your parents did. And that's why I think they need to have understanding of how to deal with people and people of colour. And so that's what I wanted to say. Thank you.
That's a really important point. And for those of you that have joined us on a weekly basis, you will know that one of the things that we're really keen to do, and we have done throughout, is to have Black doctors who come and present, because we are aware of the specific nuances of being a Black person presenting to healthcare. And the fact is that as we go forward, we have more and more Black doctors in different aspects of healthcare who are influencing some of these things. Now, we've had talks on fibroids. We've heard stories of people who were offered really radical surgery when there are alternatives, and can now choose, though, to go to a doctor who perhaps understands them better. We know that we have Black psychiatrists who understand the nuances of working with Black people better as well. When I first became a consultant 20 years ago, there were very few Black doctors. If we tried to do this 20 years ago, we would have run out of we wouldn't have had as many people who could have come to talk to us with such authority in the different areas of specialisms. But we're lucky because more and more Black doctors and medical students are going into the profession. We've got Black nurses, and there are, I don't think there'll be a trust in this country that doesn't have doctors, consultants, junior doctors, nurses, and other health professionals of colour. So it does mean that when you are, we have, one of the people I'm trying to get to come to speak to us is a Black dermatologist, because we know that if you're writing policy, you need to be able to look at the whole sphere of the patients you'll come across, and not just the narrow sphere. And because we're now in positions where we can influence that, we're helping to make sure that even our white colleagues, because the fact is that there are many more white doctors than there are Black doctors, and many of us will continue to access services from them, but we need to educate them on the different nuances that you might have for having Black patients. So Rebecca is back. Nice to see you back, Rebecca. We lost you, but we have been going through the questions that people have put in the chat, and I'm not an expert, so I've just been fielding, and I'm really pleased to see you back.
Oh, thanks, Ngozi. I'm really sorry about that, guys. I take Zoom meetings and this never happens, so I've had to hotspot on my phone. So I apologise for that.
That's fine. It's the new world we live in, which has its advantages, because we probably wouldn't have been able to reach out to as many women as we have done today if we didn't have it. But we'll just take the problems that sometimes come with that. So back to you, Rebecca. Thank you so much for what you've been saying. It's generated quite a lot of chat.
Yeah. I just wanted to add to your comments and the previous lady's comments about when you have postnatal depression and the fear of losing your child. And I think things that the tides are changing, and I think we have over 56 women in this room who'd never got this post. So I think there's power in us coming together and supporting each other, which is what I meant by community. And also the governments now recognize the fact that it's important to invest more money at that pregnancy stage when people give birth. So they've now less likely to lose your child. I think when you present to an environment that's not used to women with depression after they give birth, they're less likely to treat you as well. So I think those hubs are a good step forward. And actually, I do attend the NHS England Mental Health Hub. Every single session, they're talking about the Black provision. And actually, we need more Black people in those settings, because there's a gentleman there that represents CAHN. He's phenomenal. And if we can get more of us, if 5 of us from this room can go onto those boards, it changes the narratives for us. So thank you for sharing your experience. Do you want me to continue the presentation? I just wanted to touch on treatment.
Yes, please. I think where you'd got to work community and treatment, I think that's an important aspect as well. Thank you.
Thank you. Okay, so the next part was, where can you get help from? So as we said previously, you need to create a circle around yourself of people that are not judgmental. That includes health professionals, as well as your friends and family. And sometimes you need to go outside your circle to actually get that help. And I think people that, as I mentioned before, that illegitimate your feelings are not the right people to be speaking to. You need an environment where you can speak openly and talk about every and anything. And sometimes that means going to a professional environment to get that help. Your community, CAHN is an example of a supportive community. Dr. Ngozi's role, helping you to speak out about your experiences, I think is an important thing that we need to create more of. I know CAHN works across the whole of the UK, and that's the kind of work we want to continue. Health services, so a GP. So I think we live in a country where you can choose whichever GP you want to see. So if you find your current GP is not helping you or giving you the help you need, move to another GP service till you find someone that will take ownership of you as their patient, and you can talk to them and they're receptive to your feelings and get you to the right services. There's community mental health teams. Unfortunately, you can't self-refer into those services, but your GP can refer you into a community mental health team should you need it. And then you've got the 111 service. You can also speak to them. They have what we call the directory of service. So the beauty of 111, and I think it's growing, is that they know they have a directory that has every single service in your particular area. So they can signpost you to those services. And sometimes they also have access to some of your notes so they can give you support while your GP may not be open. And I think when you call 111, if you find the person on the phone is not very helpful or is judgmental or doesn't understand you, you can request to speak to someone else. Don't come off the phone and call back, because that puts you behind in the waiting list. You have to go back in the waiting list. So if you find the health advisor you're speaking to doesn't understand you, you can say to them, please, would you mind putting me through to someone else that I can speak to, and don't get into a convoluted conversation with that person. It's a waste of your time. Just ask to speak to someone else. The other services, there are some self-referral services, particularly for mild to moderate end of depression. So generally, there's services like IAPT. If you go on the NHS website, if you type mental health services, it will bring up your local provider and you can do a self-referral to them. And then you've got voluntary care organizations, so charities and Black organizations. And this is something that I think is really important, because there's so many other Black specific counseling services that are developed. So in my area, we have Ebony, NAFSIAT. So you can ask your GP to specifically look for a service that has been commissioned to deliver services for Black people if you want to see a Black person or someone that looks like you to deliver your care. And then there are allied services, so other services that people form by themselves in their community to create a supportive network. And so treatments. So the diet is really important. There's been some research that's shown that a Mediterranean diet can help improve your mental health. And I think it's because of the olive oil in their diet that can increase your serotonin levels. Exercise can also help with depression. So exercise can help release endorphins. Although there's no specific data, the general consensus is that it does help your mental health. And I think the struggle with depression specifically is the fact that one of your most prominent symptoms is you don't feel like doing anything. And all these things that we're saying you should do require you to do something. And as hard as it may be, I think getting that help as soon as possible will make your prognosis a lot better, i.e. your outcomes are a lot better. And I think, my previous slide talking about our community being being sectioned, I think a lot of it's also because of late presentation and late diagnosis. By the time you get to that stage, your mental health has deteriorated. And actually, I'm sure Dr. Ngozi would have seen it, even in our community as colleagues who don't present early enough, and they do suffer from depression. And by the time they present, it's impacted on their lives. So it can affect anyone, is what I'm saying. I've got friends who've had to take time off work. I've had colleagues who have had to be sectioned, and I think it's because of the stigma. They didn't get the help early enough, and there weren't people around them to help them. The other things I haven't mentioned here, things like journaling can help you. So practical things, writing down your thoughts and your feelings, your little wins. Sometimes just coming out of bed's a win, and writing that and celebrating that may be all you need to do when you're feeling that low. Also writing down a list so that you can have a structure to your day can also help. Because I think sometimes when you're so depressed, the days go into each other and you lose trail of where you're at. So sometimes having a list of things you want to do, could be brush your teeth, something as little as that is a win. Coming on to medication, within our community, we do have, there's a perception that medication is a bad thing. But I think we need to change the narrative, because if you had a headache, you would take paracetamol. It's the same thing. Physical and mental health are the same. It's And there needs to be parity of esteem between the two conditions. We can't differentiate them. The same effort you put into treating a chest infection should be the same effort you put into treating your mental health. So with medication, we tend to keep people on them for about 6 months. There are three main categories: SSRIs, which is selective serotonin reuptake inhibitor. Serotonin is the happy hormones you get in your brain, so it tries to keep the levels of that hormone, naturally occurring hormone, in your brain as high as long as possible. It can take up to 6 to 8 weeks for that to work. And we see an improvement in about 50 to 70% of people improve on that medication. However, there's some people, 3 out of 10 people, it's a placebo effect. And it's not for everyone. And it's working with your GP or your healthcare professional that you can find out whether that's going to work with any of them. There are side effects. In life, everything has risks. There's nothing that's 100% guaranteed. So you may get abdominal discomfort, vomiting, or headaches, but those tend to settle. Some people describe changing their libido, but actually sometimes between classes of medication, I found some patients that I treat with fluoxetine may get a low libido, and I have to switch them to paroxetine, and it doesn't have that effect. So there are different types, or citalopram. And then you've got TCAs, which is tricyclic. The tricyclics, they kick in between 2 to 4 weeks, and they're not only used for depression. Actually, some people may know them. Amitriptyline, use them for pain, so back pain, neuropathic pain. It's really good for in the low doses. Some people for diabetic foot symptoms, neuropathy, you can give them tricyclics. Same improvement rate, 70%. It can cause dry mouth and GI symptoms, so gastric symptoms, stomach upset, but those tend to settle after a few weeks. And then the older ones are MOIs. We hardly use them, and they have a lot of side effects. We would only go to that class if the other two haven't worked for you, or if we need to use in combination. And it tends to have a lot of side effects and can interact with some other medications, so it needs careful monitoring. And obviously, there's some other drugs that we may give you, like propranolol. As I said, some people have depression and anxiety, and propranolol can help with your anxiety. Therapy, so talking therapy. I know some people may have had negative experiences with therapy. I always tell the people the story of someone I know that went to see a therapist, and she's from an African background. And when she described her home situation, her husband doesn't cook or help out as much. The advice was to leave her husband, because she didn't get the different culture and didn't understand her truth. So sometimes I think people have experienced those sorts of negative or inappropriate advice because it's not culturally appropriate. And as I said, only 10% of the therapists in this country are from a BAME background. So that's some of the work that needs to be done to improve that. If we can get more of us into being trained, there's some work being done across UK actually. In Tower Hamlet, for example, they're doing associate training, and they've got funding for that, and they're taking people from their community, so making sure that it's people that look like the people they want to deliver that service to. So Black, Asian women are being put into this training program, and it's a master's degree. So those are some of the things I think we need to change in this country. So there's interpersonal count therapy, there's CBT therapy. So the interpersonal looks more at your relationship with people that may be the cause of your depression. CBT looks at the way you think, and then there's group therapy, family therapy that may help. There are some alternative treatments that you can use. This is in my area, so I don't want to pretend I know a lot about it. You can buy things like St. John's wort, although it hasn't been proven to work. Some people do swear by them that it does help with their mental health. Omega-3 oils are really good for your mental health also. So I think, and I think following the COVID, we all realize that there are some other things that do help boost your immune system and can help other parts of your health, but it's not my area of expertise. Other things I haven't mentioned here is things like yoga and meditation are fantastic for zenning you and also giving you balance when you're feeling anxious or depressed. Sorry, I didn't mean to talk for long. I am on social media, so if you want to drop me a DM, if you check my link tree, you can do a PHQ-9 on there. And what I do say to people is, if you don't know whether you have depression, take a PHQ-9, and if you meet the threshold, get some help. And for people who are avoiding getting help, if you decide to do your own thing, i.e., maybe herbal remedies or seek help from other yoga, the way to benchmark how well you're doing is doing some of these tests. You can do them yourself if you don't want to see someone. So if you find that that score's going up, get help. That means what you're doing is not working. We do have some free suicide training coming up. Mine's going to be in London on the 27th, and CAHN is running one on the 19th of November. Thank you, Dr. Ngozi. Over to you.
Rebecca, that was amazing. That was really, really good. And from the response we've had in the chat, I know that you've generated quite a lot of engagement and you've answered lots of questions. People are listening, so they're asking specific questions. So I'm really pleased that you address there's something that comes up in almost all our topics, the impact of well-being and physical health and diets. That's really important. I think it cuts across healthcare. The second thing that you've covered is the impact of religion. That's really important for us as Black women as well, to just acknowledge that. So that was really good. So I'm just going to go through some of the questions, the direct questions that have been put to you. So one of the ones I would just want to clarify is at the end, you talked about something you can do, an assessment you can do, a self-assessment. Is it possible that you can put that in the chat so that people can take that away and understand exactly what that is? Because I thought that'd be quite interesting. Because that's an assessment you can do on yourself to see where you're at if you feel that you're feeling a bit low.
Yes.
Okay.
I will do that. I'll put that in there now.
Okay, thank you. The other thing that there's a question here about IAPT.
Yeah.
And could you help us, to the person that's put this question, to understand it? And one of the concerns is that I know you address this in a sense about medicines, and that if medicines are appropriate, then that's fine. But I think one of the things that worry us is that it seems as if medication is usually the first line of treatment, when you've actually broken down the treatment you can have into different aspects. So there is the non-pharmacological interventions you can do. And I think most people would be comfortable with starting with that first. What's your response to that?
I myself, as a health professional, I'm always learning. So I think Dr. Ngozi will agree that there's no competent physician that will ever force you to do anything. It's a collaborative effort when you come to a health professional for help. If you feel more comfortable doing something alternative, as long as you're monitoring your health, that's all I say. So do a PHQ-9. If you decide to do something alternative, just do a PHQ-9 before you do start it, and do one within 2 to 4 weeks of starting it. It's usually 2 weeks to make sure whether it's getting better. So the PHQ-9 will give you a score. And if you see that score's getting lower, then what you're doing is working. If it's not, then you need to do something different. You can't keep doing the same thing.
Okay. So that will address where, and I think one of the things that we've also stressed in these sessions, that, you know, the old paternalistic style of relationships between you and your healthcare provider, your GP, your doctor, the hospital is gone. You need to take account of your own health. And that's one of the things that we're hoping these sessions provide, to give you some information, but also to encourage you to see your health needs as a partnership. So nobody can force you to do what you don't want to do. There's always the option to ask for clarity from somebody else, for a second opinion, but really it's a partnership. And you know, the expert on your body is you. So I'll go to one of the other questions. And I think we addressed some of this when we had the interlude, the forced interlude, and that was about postnatal depression and stress. And somebody asked a question about financially, that it says here, I'll just read it out. It says So prenatal and postnatal depression is something I feel gets overlooked when it comes to black women. And that there is a real fear about presenting to services because of the worry about the label, 2, about what happens to your children. And so people would, instead of trying to get help, would be worrying about the implications of that. So what would your advice be?
I think I hope no one comes. I think take a witness. And when I say a witness, I think take an advocate. Communicate what's going on with you with someone that you trust. You can go to even CAHN and say, is there someone that you can link me with that I can discuss my problem with? And then they go with me to the GP. We will never say no to that. And I think when your mental health is affected, your judgment can be impaired. So you may want someone supportive to come along with you. It could be a family member. Take someone with you if you don't trust that they're going to support you without taking your children away from you. And what that does to that health professional is say, actually, there's someone else in the picture that this person is speaking to, and not just her and her child alone. If you can't find someone to go with you, write a list. And that list must include your fears. I'm worried that you're going to take my child away from me, which is why I haven't presented to you. I love my child, and that's why I'm here. And make sure that health professional documents that in your notes. When they say, you can say, please document that that's how I feel. And I want that to be represented in my notes, because when they even do a referral to someone else, those notes go with them so they can see where your mindset's at. You're not there to harm your child. You're there to make sure the environment you're creating for your child is a positive environment. And if you find the person you've met is judgmental, you can end that conversation, go to reception and ask to speak to the manager and get an appointment with someone else. Or self-refer to mental health services yourself. And I think when they're coming up with a health plan for you, make sure it should be in partnership with you. When those plans were designed, the care plans, the key component was that it was a collaborative plan that you've been involved with in fully. So I think reading up on your rights, writing down what your needs are, try to find someone to be an advocate for you. And don't feel, I know your self-esteem is affected because you feel you're a bad mom, but you have nothing to feel bad about. I went through when I had my child. I was in bits. It can affect anyone. So I think seek help early enough. The earlier you seek help, the better, but from the right place and the right person.
I think that's really important and a really good advice you've given there, because many people wouldn't think about taking an advocate with them. And when we say advocate, it can be just somebody else to just witness what went on. That's a really good idea, which I probably wouldn't have thought of myself. Because as you say, I think it's, everybody expects that you'll be doing exactly what you'll be doing after you've had a baby. And the fact is that you cannot operate at the same standard, have your house the same cleanliness. Some people are superwomen and you think, well, I can do this. And very often you get in a bit of bother if you just try and do everything as you were doing beforehand. So that's really good advice. And I hope that there are people here that will take that away. And not just only for that, but any consultation that you feel worried about. We've had, as I'd said before, we've had people who have shared their stories with us about all different aspects and really concerned about the interactions they've had with their doctors. I think taking an advocate with you if you're worried about, the advice you're going to get or any aspect of that consultation is a good idea. And CAHN has that. Some Freya's said that's important to say. We've had an advocacy service for these very reasons. So that's great, Faye, for putting that in. Thank you. Thank you. So some of the other questions we've got here is we have been to try and get interventions with non-pharmaceutical, but they tell you that there isn't anyone that you can speak to. I think apart from medication, all these other interventions are on the NHS.
Sorry, just repeat that, Ungus.
So apart from medication, these other interventions are NHS treatments, are they, or are they private therapies?
So apart from the NHS, so do you mean interventions like counselling and things?
Yes.
There are, so in London, and I'm sure CAHN would know, there's some that are funded by the NHS. So the ones I spoke about are funded by the NHS. When I commissioned, we paid for that service for our community.
Okay.
Yeah.
And has in terms of things like waiting lists, have they got has the COVID had an impact, and where we are with that?
It has, unfortunately, had a detrimental effect on our waiting times and our waiting list. And although they have put more money in it, the waiting list has been impacted. But that's why they're now trying to also fund a lot more charity organizations who are qualified to deliver some of those services to try and minimize the impact of that on the waiting list. But the job of your GP, but GPs are also stretched, is to also support you during that time. I forgot to mention, they can also provide you some resources to do some self-help, and some areas also have commissioned video consultations. So there were a few that we used to use, but they've increased that provision. So places like, there's a Kooth won a big contract, I think, in London to provide online counselling service. Sorry, this is on because I'm using the internet for the computer. So Kooth was commissioned, for example, to deliver online services. Fantastic organizations, I'm sure, like CAHN, also are an example of other voluntary care organizations that can help impact the waiting times.
That's good. And I presume GPs can also refer, this question here about with things like physical activity, group therapy, they have the ability to do that as well, do they?
Yes, and there was new funding that came out, let me think, when November? It came out in August, where they released a pot of money to GPs to be able to refer you to, is there any GP, don't quote me, I think for physical exercise, I think it's any GP, any gym you want. And part of that is to address both obesity and mental health. But if you speak to your GP, they'll be able to find out. If I find it online, I'll post it in the chat function.
Okay. So the other thing I was just going to, whilst we're here, and we know that the figures are going up. The people who are here today can't have failed to notice that the figures are going up with the number of COVID cases. And so they're asking us all to have our boosters at the moment. So just wanting to just plug that if you are here and you haven't had a booster, if you've had first of all, if you haven't had your vaccines, we always say please have your vaccines. And if you haven't had a booster, please think about getting a booster so that we can everybody keep safe. So one of the directors just pointing out about the fact that we also have, I think it's covered under some of the things we talked about the stigma and the shame of having a mental health diagnosis. Do you think that's still a problem in society? Or do you think that there is so much support now that this is something that is you don't see?
I think things have improved. I don't think it is where it needs to be. I think getting a lot of faith organizations to drive that change is important. And I think a lot of them have recognized that. And that's one of the changes that have happened. Actually, I think some faith organizations now have funding to deliver therapy. And I think that's a big part of our identity. Within households, I think there's we still need to push it. And there's 62 of us in here. And I think we all have work to do within our community to change that. That includes talking to our children about it. I've seen there's been a spike in our children, actually. Young people, it's been massive. And I think the generational gap between them and us has made it even more difficult for those young people to get the help they need. And because we don't recognize it, we still just get on with it. I had much tougher time. It was much more racist when I was younger, so you should be more resilient. So I think we still have a lot of work to do, particularly for our young people.
Yeah, that's a really good point, really. As a paediatrician, I've been involved in some of the discussions We know that it has really hit children very hard. Many children have had a really rough time, their exams, doing online teaching away from their peer support has had a really massive impact. So waiting lists for child and adolescent mental health support has just gone through the roof. So they are putting extra resources into that. And the comparison, as you say, is not helpful. The comparison of your time and my time, my time as a junior doctor in this country will be very different to my daughter's time as a junior doctor, thankfully. And I don't tell her to just get on with it because she's having a better time than me. Her worries and fears are valid, and as adults, we should be there to support. Doretta, I can see your hands up, and maybe I didn't.
Yes, I was just going to say
the question as well as I should have. Like you put in the
chat. When I did it's supposed to say STV, which is speak, talk, and voice. Where at the moment we're talking about it, so that's great that we can have opportunities like this to talk, but giving people the opportunity to speak without feeling fearful or feeling ashamed, and also being able to voice how we feel, how we really feel, because if we're not able to have this SVT, we will not be able to control it, to help, to support, and channel where we're supposed to channel people in the right direction and get the right help. So when we look at it, make sure that we can speak about it, we can talk about it in sessions like this, where we have an open session, or we can have a private session somewhere, and then we have a voice so we can voice it, because that SVT is very important. Speak, voice, talk.
Thank you, Doretta. Do you want to make any comments about that, Rebecca?
No, I think spot on, Loretta. Thank you for sharing that. I think that's the key in our community, isn't it? We need to talk more, be honest, and I'm going to coin, if you don't mind, your acronym from now on going forward.
Yeah, it was.
Yes, that's fine.
Yeah. Have you put in the chat the aspect that we can sort of do ourselves? You know what you were going to put.
Yes, I have. It's there. So you can click on that link and it will score you and then tell you whether you're mild, moderate, or severe, and then you can then.
I suppose the value in that as well is that you can use that score to track.
Yeah. Because
the fact is that everybody feels a bit low from time to time, and it depends on what support you have around you sometimes, how quickly you access help. Yeah. I think that would be really, really helpful as well. I think today's been a fantastic session. We've got lots of comments about how helpful they found your session today. I think winter is coming, and there doesn't seem to be the let-up that we felt there would be. I think, people are a bit worried because we still have an impact on our health service of this dreadful disease. So I think my final message to everybody here is to stay safe. Please use the resources that we've added into the chat, and I know that once this meeting finishes that it closes down. So if you haven't had the opportunity to copy it, we'll make these resources available on our CAHN page for you to look where the links are. I'm really pleased that we ran this today. I think we probably will ask you to come back again because it's such a topic of interest, and it's a topic that all of us would have really valued and I think has had an impact on everybody today. So thank you very much. There aren't any more questions, but it's been a really amazing session. I'm going to hand over to either Faye or Charles now to just tell us what's coming in the next few weeks, especially because it's still Black History Month. So thank you. Thank you, Rebecca. That was amazing.
Thank you, Ngozi.
Thank you, Rebecca. That was absolutely fantastic. And you can see from the attendance, and also on YouTube as well, we're live streaming to YouTube, so there are people watching on there as well. So thank you again for that excellent presentation, and we really look forward to seeing you again, because we know that you do many other things as well, so we would love to have you back. Thank you, Ngozi, again for hosting as usual and fielding the questions and filling in as well when Rebecca slightly disappeared. So your excellent hosting skills are able to facilitate that really well. So thank you. So going forward, yes, it's still Black History Month. We've still got lots of activities going on, for the rest of October. So please, look out in our Black History Month directory. There's lots of different activities there. There's things going on all the time. So keep abreast of our newsletter that comes out on a Monday. There's events going on in Salford. There's events going on in Rochdale. There's events going on all over Greater Manchester. So please join in. I can't remember what's happening next week, but I do want to pull a plug for the session we've got on the 6th of November, which is all about fibroids. So given that we're looking at, Black women and depression today, please join us on the 6th of November for the session on fibroids. I know even just this week, I've had a number of inquiries from people that are really suffering and being challenged with fibroids at the moment. So please join us on the 6th of November. Other things are Healthy Hearts on Tuesdays at 6 o'clock, between 6 and 7. And we have some challenges as well with, weight loss. How do we do the one-to-one tailoring to reduce weight loss and also to increase weight management. And also we've got the physical activity that happens at 7 o'clock till 7:30. So please join us. But until then, enjoy the rest of your weekend. Reminder, please join in on Black History Month activities, support those that are going on, and we will see you next time. Thank you.
Thank you very much.
Thank you.
Thank you.
Thanks, everyone.
Thank
Thank
you.
you.
Thank you.
Bye.
Thanks,
Bye.
Ray.
Bye. Bye.
Bye.
For the good session.
Great session.
Thanks.